Good evening, everyone. Good morning, good day, wherever you are listening to us. Shalom to everyone. Hello and welcome to our 2020 Global Virtual Dental Symposium sessions, week number 5. I'm so excited on behalf of LifeNet Health to welcome all of you to our 5th week of our Global Virtual Dental Symposium in Advancing Allograft Solutions. And today we have a special guest. We have Professor Dr. Gabi Chaushu from Israel. Welcome. Good evening to you. Shalom.
Good evening. Shalom, shalom.
And I see we have tremendous people dialing in. So more and more coming. We have some people from Latin America, from the Middle East, from Europe. I also have to say hello, hola to Dr. Ocampo from Colombia. She will do the translation today on the channel for Spanish speaking. Here are some house rules for you. Please remember, if you have questions today during the sessions, use the Q&A chat and ask your question in Spanish or in English, and we will, after the presentation, ask Professor Chaushu this question. For Spanish-speaking attendees, please tune on into your translating channel. There's a small symbol on your screen, and Dr. Ocampo will translate. And one big question and one reminder for you all: after you are dialing out today, please do the survey, just 3 short questions so we can improve ourselves. So what do we have today? We have, as I said, Professor Gabi Chaushu. He will talk today in the first presentation about the predictability of using block allografts for bone augmentation. And in the second presentation, he will delight us with the use of cancellous blocks allograft for sinus augmentation with simultaneous implant placement in the atrophic maxilla. So for all of you who are not familiar, who is Professor Dr. Gabi Chaushu? Professor Chaushu is the head of the Department of Oral and Maxillofacial Surgery at the Rabin Medical Center, Beilinson campus in Tikva, and also of the same department at the Maurice and Gabriela Goldschlegel School of the Dental Medicine University in Tel Aviv. Professor Chaushu has published over the last years tremendous number of articles in English literature and has an extensive experience in dental implant surgery. So his specialty, and we will see it today, is the field of dental implantology, sinus augmentation, immediate implant placement, and ridge augmentation, of course. So thank you, Professor Chaushu, that you are here. Thank you to Hospital Innovation who made it happen that we could set up so fast these fantastic meetings here. And I wish you all over the world, wherever you are, a fantastic presentation by Dr. Chaushu. So now the stage is yours.
Thank you very much. Thank you, Peter. Thank you very much. Well, first of all, I would like to thank you guys, LifeNet, for organizing this Congress, this webinar Congress. And it's been always a pleasure to work with you both scientifically and clinically. And really your products help us a lot to promote the health to our patient. I would like also to give a special thanks to HA Systems in Israel, to Fanny and Real Gross for doing a great job in Israel. And we see them influence a lot the Israeli market and improving our clinical success. And last of all, I would like to thank you, the audience, for taking your time in those precious days of Corona and listening to some of our experience with cancellous block allografts. So now let's go to work. I'll try to share with you within the next hour some of our experience, knowledge, and scientific data on using cancellous block allografts for different things. Okay, so first lecture we'll discuss about the predictability of block allografts, which is really something that is questioned, unfortunately, still by some of the people. If you look at the literature that was available, let's say 5 to 10 years ago, many people were claiming that, yes, it's okay, block allografts can work, but we still don't have enough evidence. We still need a lot of experience. It is more difficult, and so on and so on. So you wouldn't see many people trying to use those block allografts, and basically the use was more in the hands of pioneers. But when you look today, and this is a review from 2020, and you look at this review, you can clearly see that everybody nowadays accepts that allogeneic block allografts are a very good alternative to autologous bone grafts, and they have relatively low block graft failure. They achieve similar augmentation results, and of course you get rid of all the morbidity that is going together with autogenic block grafts. And if you look at the different anatomical areas in the oral cavity, the most researched area is the anterior maxilla, and most of the studies deal with horizontal ridge augmentation. So looking at this systematic review, comparing allogeneic with autogenous bone blocks, it definitely demonstrates that there is really no difference in the success of horizontal ridge augmentation between allogeneic blocks and autogenous bone blocks. So basically, there is no reason to go for a donor site with all the morbidity as we did up to now. Well, we believe that the success comes from teamwork. We don't believe in all-in-one. I know that many practitioners around the world are doing it all by themselves, and it's fine. I don't interfere with whatever anybody else is doing. But here in Israel and in our team, we believe that teamwork is the key to success. And we've been working together for the last 17 years, myself and Professor Joseph Nissan, who is the head of the Department of Oral Rehabilitation in both Tel Aviv University and Madison Medical Center. And when we started working together, a lot of people were saying that we are crazy and we should not be listened even. But today, I think that we're in a good place after 17 years. And as always, you know, if you're doing some pioneer work, there will be a lot of people that will laugh at you initially, but eventually they will join you. And we've done through the years more than 1,000 cases. So we do have some experience in using the allogeneic block grafts. And just going briefly, you can see that we managed to publish together more than 23 articles on the topic. You can go into the PubMed and put our names. You can put Chaushu and Nissan, and you'll get all those articles. And I will try to show you today some 3-4 more articles, new ones that we sent for publication. And we're working on it continuously. We now are working on 10-year follow-up, and I hope we'll publish it soon. So we've been working on this, as I said, for 17 years, from 2000 and 3, 2004. So let's go to the first area again. As we said, horizontal augmentation is predictable. And if you look at the anterior maxilla, most of the augmentation that is required is horizontal augmentation. And again, if you look at this review from 2014, again, the conclusion was there is no problem to reconstruct the atrophic maxilla with allogeneic bone blocks. Another study that was published recently, again, May 2020, a systematic review, again, demonstrating that allogeneic block graft is very good for lateral augmentation of the anterior maxilla. So I think if we speak of all the areas in the oral cavity, the horizontal augmentation of the anterior maxilla is probably one area that is not under dispute, and everybody agrees that there is really no reason to use autogenous bone in this anatomical area. Well, we would like, of course, to show you our results, and this is one of the first studies that we published already in 2011, demonstrating the ability of cancellous bone block allografts to augment the anterior maxilla. But you know, trying to stay in the past is boring. So let's go to an article that we recently submitted to the International Journal of Orthodontic and Restorative Dentistry. We already did the 3 revision, and hopefully the article will be accepted and published. I'm quite optimistic about that. And this article is basically dealing with the ability to use cancellous block allograft for a construction of the alveolar ridge following implant failure associated with severe bone loss. And why is that important? Because if you go in an area that suffered from failure, then you have lower chances because the bone regeneration potential is lower. You might have scar tissue, and that's why theoretically your chances for success are lower. On the other hand, if you can use a material which is non-autogenous, it will be much easier for the patient to accept doing the procedure again, because the patient already did the procedure, he's already tired, he already suffered from pain and morbidity. So if you manage to lower the morbidity, then you have higher chances to succeed. Now, this particular case, this lady came to me and said, well, I had an implant that was placed in my anterior maxilla. I want you to take out the implant. I want you to do the bone graft. I want you to place an implant. I want you to do immediate loading. And I want to go out of your clinic with a nice tooth. I said, well, I also want to, but I'm not God. I wanted to be born God, but I was born human. And then she says, oh, you're stupid. Everything that people told me about you is not true. I thought you're a good doctor, but I see that you're not a good doctor. I said, what can I do? So she left and went to a better doctor. And when she went to this better doctor that promised her everything managed to take out the implant, but together with taking out the implant, he managed to destroy a lot of her bone. And then she came back to me and she said, you see, it is your fault because you didn't convince me enough to stay with you. That's why I had to go to another doctor and suffer from a bad result. So I said, look, lady, if you came back, then we're going to do everything step by step and not immediate loading and not immediate anything. And well, she didn't have much choice, so she agreed. So as you see here, this is when we opened, you see the image. Clinically, it doesn't look so bad. But when you look after flap elevation, because she had a sick biotype, so you can see here that we put the cancellous block, and the fixation is really not important. You don't have to do rigid fixation like in fracture. You need a fixation. It doesn't have to be by the rules of the AO, whoever is a maxillofacial surgeon. You just need a fixation. And we always cover the cancellous block allografts with allograft particles. And we always cover everything with a long-term lasting membrane, in this case, O6, which is a cross-linked sucrose membrane that helps us preserve the bone volume a long time. And of course, soft tissue release and primary closure. So you can see that after 4 months, we have quite a nice result radiographically and clinically. And we can go open up, look at the amount of bone we have. You can see that we still have remnants of the membrane. And we take a biopsy to change the histology and to check the histology and some morphometry. This is a 3i implant in place. It was still external hex in those days. And you can see beautiful bone all around the implant that was created. And now we can do what we call immediate aesthetic restoration, because the occlusion allows us to do that. And eventually, Professor Nissan used zirconia abutments and zirconia crowns. And this is the final result. She did also some laminates, and eventually she was happy. So we did some more studies on that, on congenitally missing teeth, and on, again, had good results. And on post-trauma, because we tried to see the ability to use the allograft in different clinical situations, and also what we call immediate non-functional loading or immediate aesthetic restorations. And we, with our co-author George Romanos, who I'm sure you all know. So basically, we managed to demonstrate in all those studies that we can augment the anterior maxilla and get a very good aesthetic results. One of the studies that is now going on is trying to see in the long term the pink-white aesthetic score, and the results are really very, very promising, and hopefully we'll publish this soon also. Well, let's go to the histomorphometry, because a lot of people tell you, well, you put their dead bone, it remains dead bone. Well, it's true. It's basically, if you want to think of it, it is dead bone because you don't see any cells, but around the dead bone, you can see a lot of new vital bone going around. So this dead bone eventually turns into new bone. And one of the things that we know about it is that this process is age dependent. One of the studies we published recently demonstrate this age dependency over 150 cases, more or less. Well, what about the posterior mandible? When you go to the posterior mandible, the problem is different, because the main problem in the posterior mandible is not horizontal regeneration, but rather vertical regeneration. You need, in some cases, horizontal, but it is more important to do the vertical regeneration. And the reason is that when you lose bone, even though you can use short implants, crown implant ratio, and especially crown height space, this is a problem. It is less important the crown implant ratio, it is more important the crown height space. And if you try to splint, it will not help you, as you see in those two articles. So again, we raise a full fixed thickness flap. You can do those perforations. We don't have too much time to speak about those perforations, but if you believe in them, you can do them. If not, you can leave them out. You adapt the blocks, you do fixation, and of course, you have to release. In the lower jaw, most of the release of the flap will come from the lingual part. And you can see here vertical augmentation on both sides. And basically, this is the result after 4 months. When we open, we had here some perforations, so we had some bone resorption, but it was not significant. Look at the new bone, extremely vascularized that we have. Again, we placed implants. Again, those were 3 implants. And look at the amount of bones that we gained. In this area, it was about 7 millimeter bone height that we managed to gain and keep. So if we look at the results on the posterior mandible, they are less successful than the anterior maxilla. The block survival will be lower, will be around 80%, but still you can get a nice success rate. Of course, horizontal augmentation is easier, vertical augmentation is more difficult, but you still can succeed and get quite a nice result. And if you look, for example, at this case, again, this is a horizontal augmentation, and look at the amount of bone that we managed to get. The bone resorption following the augmentation is around 15%, no more, and the result is really nice and long-term. Again, histomorphometrically, as you see in this study, you can get new bone formation. And as we said before, the new bone formation is age dependent. And if we want to go to the most difficult application, which is the severely resorbed mandible, we know this problem for many years. Marx demonstrated through his article by a submental approach the ability to tenpole everything. And Marx, in his study, is using posterior iliac crest, placing the implants immediately, and he really manages to get very nice and very good results. But again, we have 2 main problems. Again, this is an article that was recently submitted to IJOME, and we're waiting for the review. This is a case that we did. Look here at Blur class 3 atrophy, less than 10 millimeter height, as you see here. You know, every place I present this case, there is always some genius that tells me that he can put an implant in this bone. Well, whoever wants to put an implant in this bone, I wish him luck. And again, we go through a submental approach. This is the genial tubercle. And we fix here, in this case, bicortical allergenic allografts. We managed to do vertical augmentation of about 10 millimeters. We place some more particles on either side, use membranes to cover it, and close it. In this case, it is around Code and Howell class 4 to 5. We did also lateral augmentation, as you see here, with blocks on the maxilla, covered it with particles, membrane, primary closure. We did some small sinus augmentation and subantral elevation. And you can see here, we have a completely new mandible. We started with 3 millimeters, and now we have a completely new mandible. We had a perforation here, but it was not a problem again. Look at the amount of new bone that we have from a 3 millimeter mandible. And this is basically how we started. And this is how we ended. Again, because it is Israel, the patient was very unsatisfied because we could not provide a second molar on this side. Well, what can I do? I'm not perfect. I'm just a maxillofacial surgeon. Well, I'm not going to go with you through all this. This is the data again. In histology, we have very nice results with very good newborn formation. And finally, just to show you that we can use this also in pathological cases, this is a case, as you see here, of plexiform ameloblastoma. And this was recently published in Medicina. And again, this is removal of the tumor. This is the result at the end of the resection. And again, we did here a submental approach. You can see the bone missing. Adaptation of a cancerous block allograft, fixation with the plate, and added particles and membranes, as we always do. Closure. And you can see here how nicely we get this bone. Of course, we could have done here destruction osteogenesis, but we thought this would be an easier process. Look here at the nice new bone that we have after a pathological resection and with implants in place. So, because we don't have so much time, I try to show just a few cases and some of the studies that exist, but I hope I succeeded to at least convince you a little bit that the gold standard today is no longer autogenous bone, and I think that the gold standard today can easily be allogenic bone. And of course, I would like to thank my colleagues in those studies, Professor Joseph Nissan, Professor Marilena Vered, and my wife, Dr. Liat Chaushu, which is a periodontist and joined our group. And of course, I would like also to thank all my colleagues at the Department of Maxillofacial Surgery at Bennington Hospital who are working with me on all those studies and articles. And thank you very much. And now, if you have any question for this first part, and I'm able to answer, I'll be happy to answer.
Thank you very much, Professor Chaushu, for this presentation. Very interesting. So there is already one question. In the aesthetic zone, some authors have suggested corticocancellous block is better. What is your opinion about that?
Well, basically, I don't think that anybody suggested that corticocancellous is better, because I haven't seen any comparative study between cancellous and corticocancellous. And from my own experience, both of them are feasible. The big difference between cancellous and corticocancellous that people have to understand is that if you use cortico, then you need to wait until this cortical bone is resorbed and new bone is formed. So eventually you will lose more bone, because if you use a corticocancellous, it is exactly like using autogenous bone. And then you get the resorption of the cortices, but you lost the volume. So eventually you turn up with less volume. And when you use cancellous bone, it just serves as a scaffold, and you get new bone formation from the start. And instead of getting your protection from the cortex, you get your protection from the particles and the membrane. And this way, on one hand, you maintain the original volume, and on the other hand, you do not get resorption because you are protected by the particles and the membrane.
Yeah, thank you. So now more and more questions. Do you use any growth factors?
Yeah, growth factors is really now the new issue. I didn't have the time to speak about it. Growth factors are very important because growth factors will give you two things. First of all, is better angiogenesis, which is important when you use allogenic block, because vascularization with autogenous is better than with allogenous. So when you do use growth factors like BMP, which is both angiogenic and osteogenic, you get better angiogenesis and you get more new bone, and faster newborn formation. So those factors will help you a lot, and they are clinically, they are less important in horizontal augmentation. They are much more important in vertical augmentation.
In the vertical, yeah. Do you rehydrate the allergenic bone block prior to use? And if so, which medium are you using? You use blood or saline or? Yeah,
I do rehydrate them. And for me today, the best solution to rehydrate them is BMP. Okay, I usually rehydrate them with BMP. I don't use the BMP with ACS. I always prepare the BMP and I rehydrate the allograft, the particles, the blocks, and the membrane with BMP. This is the best solution to rehydrate them.
Yeah, thank you. Here is one question: from which manufacturer you choose your blocks? You stick with one manufacturer?
I always work with LifeNet, not because this is your seminar, but all of my blocks are from LifeNet. I tried using other companies. Unfortunately, I didn't get the same success. So if you look at all the articles and all the studies that I'm doing, they are unique to LifeNet. Unfortunately, I have colleagues that have been using other companies, and they come back to me and say, oh, Allergenic block is no good. And then ask him, what company do you use? Do you use LifeNet? He said, no, why should I use LifeNet? And I say, okay, try to use LifeNet and then we'll talk. I'm not saying that LifeNet is the only one, but my experience comes from working 99% with LifeNet.
And the last question, thank you. And the last question here, do you believe that the membrane should last until the block is uncovered? Or, you know, Geistlich is always suggesting that only for 4 weeks the membrane should last.
Well, I completely disagree with Geistlich. I think that the membrane should last as long as you want protection. Sometimes I open, I still see the membrane, I place the implants, and I leave the membrane in place. Yeah. Because the process of remodeling and newborn formation lasts 1 year, sometimes even more. So I believe the membrane should stay there as long as possible. I stopped using Geistlich membranes in augmentations. The only place I use Geistlich membrane is if I have a perforation in the sinus. In all the other places, I use only long-term membranes.
Okay, thank you. We will go, here are a lot of greetings to you. Thank you, great presentation, great cases, fantastic.
Thank you very much.
Last one, which membrane you use, you said it already. Maybe you can repeat it.
The name is Osix. It's an Israeli product that it's sold all over the world.
Okay, so all the other questions maybe we can stick on the end if we have more time. I would invite you now to do the second presentation for us. We would like to hear something about cancellous block, allografts in sinus augmentation.
Okay, and, okay, I'll be happy to.
The stage is yours.
Thank you very much, Peter. So let's go back to work. So let's speak about using cancellous block allograft for sinus augmentation with simultaneous implant placement in the atrophic maxilla. Well, as I said, I'm not that young. I still feel young, but I'm not that young. So if we go back to the older consensus conference that was published in IJOMI already in 1998, and we speak about anatomic consideration for simultaneous implant placement. So the condition is that we want to have, in order to be able to do simultaneous implant placement, we want to have also structure of sufficient quality and quantity to provide primary stabilization of the implant. And we want to have a good alveolar and jaw relationship. And if we speak about grafting materials, nobody says anything about which kind of grafting materials we need to use in order to be able to perform simultaneous implant placement. And the main reason to do simultaneous implant placement is patient convenience. we want to decrease the number of surgeries. And of course, we need to be very careful, because if there are any known risk factors, it is better to do delayed implant placement and take less risks for the patient. So if we go back to our history with sinus augmentation with simultaneous implant placement, one of the first studies was published by my mentor, Professor Michael Peleg, who is now at the University of Miami in Jackson. And Professor Peleg, together with Professor Mazor and Aaron Gar from Miami and myself, already published an article demonstrated that even if you have 1 to 2 residual alveolar bone height, even in those situations, you can still do simultaneous implant placement. And of course, you need to ensure implant parallelism in those cases, because if you're working with particles, it is more difficult to stabilize the implants, especially if you don't have enough bone. And lucky for us, in those cases, we did manage to do both implant stabilization and achieve good parallelism. And if we're trying to think about what actually were the surgical modifications in order to achieve those results, it was first of all to use a wide lateral window opening, which is still debatable until today. And why a wide lateral window opening? Because if you have a wide lateral window opening, you have a control. And you know, if we go back to G.V. Black, you need to see what you do. If you do not see what you do, then you get into trouble. So one of the things, if you want to control what you do, is to have a wide lateral opening. The second is you need to have a bone mill to have good bone homogenization and to be able to have a good condensation. And hopefully this condensation will be able to let you stabilize your implant. We did some other attempts for stabilization, like using bone cement over the years, which was not a big success because we suffered from terrible infections afterwards. And if you look at the consensus conference, then the consensus conference says that future prospective studies should really identify what kind of quality and qualities the residual alveolar ridge should have. And this is, look how smart those guys were. They want, you need to evaluate block versus particles for immediate versus delayed placement. So we, you know, I always say to my residents when they come to me with a great idea that usually this new idea is not always so new, because if you look in the literature, you'll always find something in the direction. Of course, you can always improve, but a lot of things were said and done before. So we aimed of doing exactly this. We aimed at using those blocks, and that those blocks will help us stabilize the implants. But let's see, how did we get the idea? The idea is not completely original. We need to thank others, innovators along the way. And one of them is, of course, Fuad Khoury, who is from Germany, originating in our neighbor in the South Lebanon. And Fuad Khoury already published in this study that he was able to do simultaneous implant placement even when the bone height was less than 5 millimeters. And how did he do that? He was just using the cortex, the block, and this block was stabilizing the implants at their apices. So this was one of the first ideas by Fuad Khoury for simultaneous implant placement, and he had a very nice success. Another idea also coming from Germany is to try and use osteosynthesis plates that we use in trauma, orthognatic surgery, oncologic surgery, and by those plates to try and stabilize the implants, even in cases that you have very little or nothing in the residual alveolar ridge height. The idea was nice, but it was not practical because you had to be very precise with the implant placement. So I don't think that the idea became very popular. You see, the idea was to try and stabilize more anteriorly the bar and then splint the implants to achieve the stability and prevent implant drifting into the sinus. Okay. So our colleagues from the Department of Periodontology published something very similar to using a block and simultaneous implant placement, but in this case, they've been using BIOS blocks. And by talking to them, we realized that those blocks are very problematic because they will crack in your hand. And it is something that is possible, but it is not predictable. So we're looking for a more predictable way than blocks that are breaking in your hand. But again, I always want to give credit to my colleagues that helped me develop my own ideas. So at the beginning, when you do your first cases, you want to be as safe as possible. If you have a new idea, don't ever try it in the most difficult situation. You have to go gradually, and you have to go step by step with your cases. So when you look at this case, for example, today, you can see here that we have a Budon bone. Maybe today I would even do a closed sinus augmentation. But this case was perfect to start because I thought that even if something will go wrong, I can still manage the case and get out of it. So what we did here, we did a dovetail preparation on the lateral window that will help us stabilize the bone block. And you see, this is the bone block having this dovetail preparation. And we put particles in the area below the block. We then just press fitted the block on the lateral window. By using a surgical template, we placed the implants in an ideal position. Then all the bone that was over the window, we took it off, put a collagen membrane over it, and you can see here the final radiologic results. Of course, all the prosthetics here is done by my colleague, Professor Joseph Nissan, that I presented you in the beginning. But now we wanted to really go to the real thing, because if you want to do blocks and simultaneous implant placement in cases with more than 5 millimeter, it's not a big deal. You want to do it in cases that you basically have no bone and you're able to stabilize the implants in this kind of bone. So let's go to this challenge right now. Now you can see in this case that you basically don't have any bone in the sinus floor. You can see here it's less than 1 millimeter. So again, we prepare the lateral window and we prepare here a block in a special way. We prepare the block in such a way that the outer part that faces outside the lateral window is always bigger than the window, because if we have any problem, this will prevent the loss of the block into the sinus. Another trick that we do is that we go here in a gradual way. And when you press fit it, it will always stop somewhere. So by this gradual way, you gradually push the block inside the sinus and eventually can get enough stability by this press fit insertion. And you can see here, the block is press fitted inside. Now, in this case, we also have an immediate implant placement, not only simultaneous implant placement, but immediate implant placement, because we had this extraction. So what we do here, after press fitting the implant, you place the first implant in this area. And this will help you stabilize, of course. Then you take off the bone of the block that is more than the lateral window. You cover it with a collagen membrane. And as you see here, those are the blocks. Those are the implants and the block. And basically you see that this implant is inserted into the block, and this implant is stabilizing the block. Whereas this implant is basically only in the block. This implant has no support from the residual alveolar ridge height. And final result, second stage surgery, as you see here, soft tissue healing, press fit for the impression, and this is the final result. And this is, of course, the clinical view. Again, prosthesis done by Professor Joseph Nissan. So you see, for example, in those cases when you have minor perforations, you don't care about them, because if you have a block, the grafting material will probably not go into the sinus. But the more interesting are those small perforations that some people tell you that you have to abandon the case. Well, we do not abandon. We put a membrane, we put some particles in the lower part, and then we place a block. And we're not afraid, because once the block is fixed, we don't care about the perforation, no matter how big it is. And we cover with the lateral with the membrane. And again, you can see here's the final result. We don't care about the perforation, how huge it is, because the block gives you the bone volume, and the implant is stabilized in the block and by the lateral bony window, as you see here. And of course, the criteria for exposure are the same: stability and no resorption. Nothing else is different. We took trefines after 9 months, similar to the study by our colleagues from the perio department. And in this study, we have 28 individuals. And as you see here, we didn't have problems to stabilize the implants. We came out with a very nice homogeneous bony mass, both radiographically, clinically, and histologically. We had failure of 4 implants, which is normal, as you see here. And of course, we did also the histomorphometric analysis of this case. And look here how nice bone we have. Okay, it's true, yes, we have dead bone. Like many people say, oh, you're dealing with dead bone, dead bone, dead bone. Yes, maybe it is dead bone if you want to call it dead, but it becomes alive. You can see here that as this bone revives, then you have here very nice new bone formation. And you look at the percentage of the bone, the new bone formation is normal, is about 26%. And we didn't find differences for new bone formations between genders and between ages. In this case, there was no age difference because the biopsies were taken after 9 months. In the previous cases, we have age difference because the biopsies were taken after 4 months. So our recommendation is always, if you are dealing with older people, give them more time. If you give them 9 months, it will be definitely enough. You can give even less, but 9 months, this is what we did. Perforation did not influence the results. And also residual alveolar bone height did not influence the results and the amount of new bone formation. We had a very high osteoconductivity. We measured the osteoconductivity, which was 82%. If you look at the initial mineral contact of the block, it was 60%. We had a merely 10% volumetric reduction after 9 months, and 53% of the block was replaced with new bone after 9 months, meaning that we still have a remodeling process, but it's fine. We don't care because once we have enough vital bone for osseointegration, the continuous remodeling will not affect us. So if we want to discuss it, there are actually 2 major concerns in the one-stage procedure. One is initial stabilization of the bone graft, and the second is initial stability of the implants. The bone graft completely fills the sinus, as you see here. And the initial support is gained from the bony walls. And the stability of the implant is achieved by from the block and from the residual alveolar ridge. So you have two places that will give you stability. Perforations are really not a problem. We had 21% perforations, but we didn't really get too excited because of that. So I hope I managed to convince you that we can use cancellous bone blocks for sinus augmentation and simultaneous implant placement. And as I told you, I want to share with you also new studies. And this is a study that was recently published in Nature Scientific Reports, in which together with colleagues from the departments of perio, oral medicine, oral rehabilitation, pedo, oral pathology, we try to assess what is better. Is it better to use particles? Is it better to use blocks? Or can we define any conditions that using blocks will give us any advantage? So we compared clinics, radiology, and histomorphometrics of the outcome of simultaneous implant placements in block versus particles. Of course, consecutive patients, of course, only cases of less than 3 millimeters, and we took biopsies after 9 months. We had 38 sinuses. In 4 cases, when we use particles, we could not stabilize the implant. So we just did the bone graft and used only a second stage insertion. Whereas when we did the blocks, we were always able to stabilize the implants. We had a nice success. And bone gain was basically the same, a little bit more for the blocks, but no dramatic results. On new bone formation, again, a little bit more for the particles, but not statistically significant, which is normal because the vascularization of the particles is a little bit better than of the blocks, but this is not of clinical significance. And if you look here at the histology, again, histology was very similar. New bone, connective tissue, residual block, new bone, residual particles, and so on. And if you remember the case with 1 millimeter, on the other side, we did particles. So you can see when we compare the block with the particles, basically it looks the same. So sinus augmentation with allograft, doesn't matter particles or block, and simultaneous implant placement is of course predictable. All outcome parameters are similar when you use particles versus blocks. And if you really must do simultaneous implant placement, it is better to use blocks because you have more chances to stabilize your implants. Whereas in those cases that use particles, sometimes you need to abandon the simultaneous implant placement and do it in the second stage. Again, it is not a disaster, but just to know if you're going, for example, if you're going for general anesthesia and you don't want to do a second implant placement surgery, then it is better to go with blocks. And again, thank you for your attention, and thanks to my colleagues for doing this clinical, let's say, ride with me all over the years. Thank you very much.
Thank you very much for this fantastic presentation. So many informations, so many questions coming out. So I have to set them up a little bit. Some of them you answered already. So first of all, someone asked if we have a recording of this session. Of course, all these sessions are recorded, and you have to contact your local dealer and from LiveNet Health, and we will provide you with the session. So Question one. Do you use a membrane over the lateral window?
Yes, the answer is yes.
Yes, this you answered already. What type of particulate graft do you use with your blocks in the sinus?
Again, I use two kinds of particle bones. Let's say in 80% of the cases we use allograft from LifeNet. In 20% of the cases we use the BIOS.
BIOS, yes. Is it necessary for the implant to have good primary stability?
Well, this is a good question. The question is, what is good primary stability? If you can find somebody that will tell me what is good primary stability, I can answer the question.
Yeah.
I can tell you that the primary stability that we had in those cases went from, in some cases, 10 Newton centimeter to 72 Newton centimeter.
Yeah.
Let's say that if I have less than 10 Newton centimeter, usually I prefer to wait and put it in a second stage.
Thank you. How do you fixating the block while drilling for implant?
Yeah, this is a good question. As you saw, I always leave more bone laterally. So whenever I drill the implant, either myself or one of my assistants is pressing the block on the outside. Mm-hmm. And then this over bone volume is taken away only after I close the implant. So the block is fixed manually by myself or somebody else.
Okay, thank you. Can you get the allergenic block designed pre-operatively according to the CT scan?
Theoretically, yes. I've never done it, but theoretically, of course. We're now in the 3D area. I'd be happy to see someone doing such a study.
Right. Nice results. Thank you, Professor. Do you have any failures with your sinus lift block technique?
Yes, of course we have failure. Only God doesn't have failures, and we're not God. And we have failures, but lucky for us, not much. We've been doing several hundreds. We had about 3 failures. And in those cases, we took out everything, waited 6 months and redone the sinus, and we succeeded.
Okay. How do you address tissue coverage in vertical augmentation in case of a tissue deficiency?
Well, it depends in which anatomical area you are. If you are working in the mandible, then you can release the mylohyoid or release the tissue from the mylohyoid, and then you have tremendous soft tissue that will help you vertically. If we go to the maxilla, it is more difficult. And in those cases, you need to do a very good soft tissue release. The first soft tissue release comes by elevating the biggest flap you can. The second soft tissue release comes by doing incision in the periosteum. And the third soft tissue release comes by releasing the muscles from the soft tissue. So by doing all these 3, and in some cases in the maxilla, by even releasing the buccal fat pad, then you can get enough soft tissue to cover your cases. But this is something you cannot explain theoretically. This is something you need to do practically and learn, have failures. Believe me, I had so many failures until I learned, but eventually I learned. So this is a manual issue.
Okay, thank you. Here is another question regarding your previous presentation. How do you stabilize the membrane in vertical augmentations? Are you using pins?
I never stabilize a membrane.
No.
I don't stabilize a membrane. I don't think it is necessary.
Okay, thank you. Are there any other questions? There is a question, Yvonne, can you translate this? It's a Spanish perforation of the membrane.
Yes, if you have any perforation on the membrane, And on the Snyder membranes, you use a membrane unblock?
Yes, I put the membrane on the perforation, and I use a block also.
Okay.
Okay, thank you for this.
Thank you.
So there are no more questions coming up. I would like to thank you again very much for your presentation.
Thank you very much, and thank you for holding this webinar. I think it's a great thing for everybody.